Dr. Anu Hazra, personal pronouns he, him, his, is an assistant professor in the section of infectious diseases and global health at the University of Chicago and director of STI services at the Chicago Center of HIV Elimination. In addition to his work at UChicago, he is co-medical director of Howard Brown Health's 55th Street Clinic, a prominent federally qualified health center specializing in the needs of LGBTQ people living in the Midwest. Dr. Hazra's research focuses on sexually transmitted infections and their effect on sexual and gender minorities and other vulnerable populations living on the South Side of Chicago. These interests are complemented by his clinical work in complex HIV management, PrEP care, hepatitis C management, gender-affirming hormone therapy, high-resolution endoscopy, treatment of opioid use disorder, and medical education. Above all, he is passionate about equitable healthcare delivery to LGBTQ people of color. With that said, Dr. Hazra, thank you very much for joining us today, and the floor is yours.
Great. Thank you so much for the introduction. I can pull my slides really quick. Perfect. Yeah, so I mean, I think today's talk is really going to focus on how to empower LGBT health and wellness in your primary care setting. Again, there'll be plenty of time for questions after, but if there's any burning questions that come up, please feel free to drop them in the chat box, and I can try to answer things in real time as well. I think the first thing is to do some sort of level setting and really ask ourselves, well, why is this important? Why is creating affirming LGBTQ spaces in healthcare important to us? And I think it's in one way just to make sure that we are sort of, again, all on the same page as how we think about gender, sexuality, and orientation. I'm not going to spend too much time on these spectra, but I do just want to make sure that we understand we're all sort of starting from the same point. We know that someone's sex assigned at birth it may be different than their physiological sense of self or gender, which may also be different from how they communicate their gender. And then beyond all of this, or separate from all this, is actually a romantic erotic response that people can have to one another, which we consider sexual orientation. And so folks can fall on sort of different ends of any of these spectra, and consider and be considered part of the LGBTQIA community. Sort of another schematic of how we think about sex, gender identity, gender expression, sexual orientation is this, again, sex really refers to the presence of specific anatomy, and we typically refer to this as sex assigned at birth. But that can sometimes differ from what someone's internal sense tells them what their gender is, which then also can differ from how they present their gender to outside society. And again, lastly, sexual orientation, sexual behavior, sexual identity are all separate from gender identity and sex assigned at birth. These are often romantic attractions, physical behaviors, or even in how folks identify their sexuality. I think it's also important to recognize the self-identification trends that we see here in the United States over the past several years. This is from the most recent Gallup surveys looking at the amount of LGBTQIA Americans who self-identify in this country year by year. And then you can see here as of 2021, about 7.1% of Americans identified somewhere as LGBTQIA or something other than heterosexual. And when we actually look at generational changes, we see that difference is much more prominent, where we see nearly a fifth of all folks belonging to the Generation Z, so folks born between 1997 and 2003, identify as something other than heterosexual. And we also see, again, rising rates or rises of self-identification in other generations as well. As we take care of all of our patients, it's important to recognize that LGBTQI patients will become a larger and larger part of your practice, no matter where you practice or what you do in terms of care. Really, to improve healthcare, I think it's important to recognize lived experiences and specifically the role that medicine has played potentially in harming a lot of LGBTQI people. In 1952, the DSM, the Diagnostic Manual, classified homosexuality as a mental disorder, which was only repealed in 1973 by Dr. John E. Fryer. John E. Fryer was a psychiatrist at Temple University School of Medicine. He actually came to the 1972 APA conference, hid under a mask, and identified as a homosexual at that time and a psychiatrist. And again, really tried to emphasize that this illness was not a homosexuality rather than the toxic effects of homophobia. And I'm going to talk a little bit more about this as we talk about social determinants of health that impact LGBTQIA people. Dr. Fryer could have lost his license for being gay at the time when it was against the law in most states. Since then, there have been other sort of, concerted efforts in harming the LGBTQI community, which included the Lavender Scare of the 1950s. Then we think about, Stonewall in the late 1960s, the FDA blood ban in the early 1980s, born out of sort of the AIDS panic then, which was only repealed about 40 years later, just last year. Don't Ask, Don't Tell, which again took nearly 2 decades to fully repeal. The Defense of Marriage Act, which again took nearly a decade to reverse, and which was codified by the Marriage Act in 2022. Today is the 8th anniversary of the Pulse Massacre, Pulse nightclub massacre, where 49 individuals attending an LGBTQ nightclub lost their lives. And then in more recent years, between 2017 and 2021, we've seen a slew of anti-LGBTQI legislation, which impact sort of all levels of the lifespan of someone who identifies as LGBTQIA. And again, as of 2024, most recently, the ACLU is tracking nearly over 500 anti-LGBTQ bills here in the US. So let's talk a little bit about health disparities. So, I always look at the difference between health disparities and health inequities. I think it's important to make this terminology difference. Health disparities are differences in health outcomes, and access to care. As of 2016, the LGBTQI population count by the National Institute of Minority Health has a health disparity population. Health inequities are when these differences in health outcomes are the result of systems of oppression and structural factors that disproportionately harm certain groups. And so I think inequities is important to think about and on a structural level, on a larger scale level in general. And health disparities should always be framed within social determinants of health. Our knowledge base is limited. When we try to sort of identify LGBTQIA health disparities, our knowledge is limited by the significant methodological challenges in conducting research in a group that's subject to bias and discrimination, both within society, but also within the medical system. And really, until recently, those living on the gender sexual continuum have not really been included or adequately identified as an important population for health-based studies. All of our main longitudinal and prospective studies on overall health never really looked specifically at LGBTQI Americans, even though, as of now, they account for nearly 10% of the US population. And it's impossible to study LGBTQIA outcomes without adequate identification and inclusion of these populations. Specifically, I always tell audiences to ask themselves, has a clinician ever asked you about your sexual health? Has a clinician ever asked you about your sexual orientation? Has a clinician ever asked you about your gender identity? If we don't ask these questions and document them, there's no way to actually understand health disparities that are occurring in these populations. These end up just becoming invisible populations, and these disparities are much more difficult to see. So, what are these social and structural determinants of health that impact the health inequities we see amongst our patients? And this is obviously not new to probably any of you. We see social determinants of health occur in any marginalized population, and LGBTQI Americans are no different. Again, these are intertwined systemic structures and determinants, which include economic stability, neighborhood and physical environment, education, food, community and social context, and healthcare systems. And all of these impact health outcomes in very intertwined ways, whether they be morbidity, mortality, life expectancy, healthcare expenditures, health status, and functional limitations. Some examples of how social determinants of health impact LGBTQI people would be thinking about access to care, knowing that enormous challenges remain for this community living with HIV and accessing quality, non-discriminatory health services. In terms of employment, where 23 states have not specifically listed sexual orientation in their laws prohibiting discrimination against public employees, and 38 states don't prohibit gender identity discrimination among public employees. In housing, that nearly 20 to 40% of all homeless youth identify as LGBTQIA. And specifically in my state of Illinois, that 58% of transgender residents in Illinois report experiencing discrimination in public accommodation settings, including public transportation. Again, I can't expect my patients to show up to clinic if they don't feel safe on the metro coming into clinic. I can't expect my patients to be able to take their medications if they are completely unhoused, again, due to the way society treats them. When we talk about social and structural terms of health, it's also, I think important to talk about intersectionality and understanding that LGBTQI people are not a monolith, that there are, several important intersecting identities that all of us have that create us as, complex three-dimensional beings. These are often overlapping intersectional social identities that also contribute to oppression, domination, discrimination, and often compounds and health disparities. In the city of Chicago, there's nearly a 25-year difference in life expectancy between the north and south side of Chicago itself. But life expectancy is nearly double. That difference is nearly double among LGBTQIA people living on the south side of Chicago versus those living on the north side of Chicago. Again, these intersectional identities of being Black and queer, living on the south side, being Black and queer living on the south side in a community impacted by gun violence. These intersectional identities all impact someone's social terms of health and their overall health outcomes, and really important for us as clinicians to be able to understand and see and be able to recognize when we are seeing or treating folks in clinic. The other thing that comes about when we think about intersectionality is the minority stress theory. And so this is thinking about, specific stressors that folks of minority status and minority identity and experience, which then lead to often poorer health outcomes and is thought to potentially, again, explain some of the disparities and inequities in health outcomes that we see. There are certain environmental circumstances that minority populations experience, and these are oftentimes what we call general stressors. Again, these could be sort of any stressors we see in our own populations that can lead to health outcomes. For someone being as part of a minority status themselves, often can have distal or external minority stressors, which can include stigma, discrimination, violence, and outright abuse, which then can clearly lead to differences in health outcomes. And then even within minority status, identifying as a minority can often lead to proximal and minority stressors or internal stressors, which can often be internalization of negative societal attitudes and rejection sensitivity, which can also lead to poor health outcomes. But it's also important to recognize that minority identity can also cultivate something we call resilience development. And resilience, and whether that be finding a chosen family, finding community, and finding strength in those communities, and that resilience can often lead to better health outcomes than those that don't have community around them. And I'll talk about a few examples in a little bit as well. Again, the stress associated with stigma, prejudice, discrimination will increase rates of certain health issues in minority communities. And these stressors are unique, socially based, and often chronic. So let's talk about some of these health disparities. In youth, we know that LGBTQIA youth, like defined as those under the age of 18, are 2 to 3 times more likely to attempt suicide, more likely to be homeless, and higher likelihood of acquiring HIV and STIs. Now, we know that 46% of LGBTQIA youth will experience physical violence related to sexual orientation. 74% of trans youth will report sexual harassment at school-based or on their gender identity and expression. And nearly a third of LGBTQIA youth will eventually drop out of school due to this harassment. This sort of schematic is asking young people what are the most important problems that they're facing right now, and comparing LGBTQIA youth compared to non-LGBTQIA youth. In non-LGBTQIA youth, we see that stressors are what we commonly think of stressors among young people. These are classes, grades, thinking about college and career, and thinking about financial pressures related to college or a job itself. For LGBTQIA people, there are other stressors that take precedence. And these are not accepting families, school or bullying problems, or fear of being open or out. This doesn't mean that LGBTQIA people are not worried about classes and exams or not worried about their college or career, but they're not given the ability or have the chance to really even think about that without first having to deal with these initial stressors themselves first. Again, LGBTQIA folks are not more likely to be homeless because they're LGBTQIA. They're more likely to be homeless because of the way society treats them for being LGBTQIA. I think it's a really important difference to make here when we think about sort of these health inequities. That's not something about sort of being a part of this community that increases folks' ability or concerns around mental health or communicable diseases. It's the way society treats them and offers them often lack of resources, inability to have a safe home or a home infrastructure, leading them to think about survival sex or homelessness, which then increases their vulnerability and susceptibility to other sort of disease processes. When we think about specifically health disparities among sexual minority youth, this is from the CDC, looking at, compared to their heterosexual peers, sexual minority students were more likely to be bullied at school, been forced to have sex, seriously considered suicide, used illicit substances, and misused prescription opiates, or felt sad or hopeless. And again, this drives home to the point that, again, the health outcomes and these differences in health outcomes we see specifically in sexual minority youth that differs from their heterosexual peers is not due to their status of being a sexual minority, but due to the way that society treats them for being a sexual minority. There are protective factors for LGBTQIA youth as well, though. We know that family support and acceptance is a huge protective factor in helping prevent both homelessness and overall downstream poor health consequences people feel. Peer support and social convoys are also known protective factors. Gay-straight alliances, this study was looking at just the mere fact of having a gay-straight alliance, not meaning how active it is, how visible it is, or if a student is a member of it. Just having some sort of gay-straight alliance at a high school significantly decreased the homophobic victimization felt by students itself. So just the mere appearance or representation of some sort of peer support or social convoy was a major protective factor. Inclusive sexual health or education, and access to affirming care. This is super important and something that's within the crosshairs of politicization currently as we think about affirming care for LGBTQIA youth, which I'll talk about towards the end of the talk today. When we think about sort of general LGBT health disparities, we know that LGBT people smoke tobacco at much higher rates than the general population, 30 versus 20%, that they have higher rates of alcohol or drug use, that MSM and trans women are have much higher vulnerability to HIV and STIs, especially among communities of color, that lesbians are less likely to access preventative services for cancer compared to heterosexual women, and that older LGBT adults face additional barriers in healthcare due to isolation, fewer family support, and lack of culturally competent social and support services. Again, these inequities are largely driven by structural differences and structural barriers that folks see. When we think about health outcomes of gay and bi cis men, we see higher rates of frequent mental distress and depression, and higher sort of smoking or current smoking status in this population. Among lesbian and bi cis women, again, we see similarly frequent mental distress or depression, activity limitation, again, increased health conditions like arthritis, asthma, and increased health risks like current smoking, binge drinking, and obesity. And then specifically thinking about trans people, we know that transgender folks experience very high rates of victimization, abuse, homicide, and suicide. The worldwide pooled prevalence of HIV among trans women is 19% compared to 0.3% of the general population. We know that unemployment is 3 times higher among transgender folks in the US than their cisgender counterparts. And we know that trans folks have significantly more likely experience homelessness or housing instability during their lifetime. They have difficulty accessing preventative and urgent care, and they're less likely to have health insurance than their heterosexual or cisgender counterparts in general. This is data from the 2015 US Transgender Survey, which is documenting any negative experiences that transgender respondents may have seen when seeing healthcare. We can see here that over a third of trans individuals had at least one or more of these experiences listed when trying to access healthcare in the past year. Also from the US Transgender Survey, we see high rates of income-based underground activity, economic experiences, which include income-based sex work, drug sales, or other criminalized sex work. Again, and we know that transgender individuals are more likely to be trafficked, and traffickers often target homeless youth and gender sexual minorities because of how vulnerable they are, which again lead to worsening health outcomes that we see in this population downstream. Even the ability to use a public restroom is often fraught with issues among trans folks. Among the US Transgender Survey in the year prior, nearly a third of all respondents were either denied access to a bathroom, had their presence in the restroom questioned, or were verbally harassed, physically attacked, or sexually assaulted in a restroom. That even public spaces are not open for these communities. And I think it's important to also recognize the impact that COVID-19 has had on LGBTQIA populations, and a lot of which have yet to fully recover. Without widespread gender identity and sexual orientation data collection, like I mentioned earlier in the talk, specific outcomes for gender sexual minorities remain unclear during the COVID pandemic, but we know that there was a loss of certain protective factors that we knew were important to this population, which included, seeing higher rates of housing security or unsafe housing, increased financial stress through the loss of gig economies that a lot of individuals in the LGBTQIA community rely on, loss of insurance and ability to access care, whether that be access to HIV antiretroviral therapy, to HIV prevention like PrEP, to gender-affirming hormone therapy, or even mental health services. And then specifically social isolation, decreased contact with chosen family specifically. Again, the care of LGBTQ folks must always be centered around these structural and social determinants of health to really impact or make any impact in general. We know there's a fear and concern about healthcare among this community specifically. And so we know that specifically among transgender folks, again, I talked a little bit about from the US Transgender Survey, this is looking through Land of Legal, where healthcare professionals may have blamed folks for their health status or were physically rough or abusive to them in a clinical setting itself. And these fears about healthcare, end up trickling into, fears of that I will be refused medical services because I am transgender, that medical personnel will treat me differently because I am trans, or not having enough medical personnel to ethically train to care for the people to care for people who look like me or who identify like me. With all of this sort of negativity, I do want to bring up at least some positivity here too, that we have data to support that, affirming care can actually help us really help in overall health outcomes. This is data out of New York City that was presented a few years ago when New York City's Medicaid actually once it expanded, actually ended up covering gender-affirming gender-affirming surgery under Medicaid services. So really opening the doors or opening access to gender-affirming surgery for a larger group or larger subset of transgender populations. And this is looking at transgender folks living with HIV and their viral suppression rates before and after their last sort of gender-affirming surgical procedure. And they saw about 2 years prior to the first gender-affirming surgical procedure, we saw about maybe a 60 to 70% viral suppression rate among transgender individuals living in New York City. This increased as folks sort of became closer and closer to the surgical date. And then when we look at years after their last sort of affirming surgery, so when they were done with all of their affirming surgery, we saw much significantly higher rates of viral suppression and the order of 80 to 90%. Again, trying to get to our 90-90-90 goals here in the United States of trying to make sure that at least 90% of all folks diagnosed with HIV are virologically suppressed. This tells us a few different things. This tells us that often trans folks have other competing priorities about their health, that while they're living with HIV, that really their gender dysphoria, having access to affirming care, and being able to have these affirming procedures take precedence over maybe other chronic conditions that they experience, like HIV. And while in our mind, HIV prevention and HIV suppression might be the first thing that we want to make sure is addressed, that might not align with the priorities of our population. And that's okay. That if we're able to provide these affirming services, we can use it as a carrot or as some way to develop a stronger therapeutic bond with our patients to then be able to then achieve what are some other metrics or criteria that we're looking for in our health setting. So with all this, how do we, create safe spaces in medicine? How do we create affirming spaces in medicine? I think, when we think about providing a range of, providing affirming care goes beyond, knowing someone's pronouns or being able to feel like enough about hormones or whatnot. It's a range of social, psychological, behavioral, and medical interventions that are designed to support and affirm an individual's gender identity. We can all provide gender affirming care to all of our individuals no matter if they're trans or cis. I think, this is, again, more than hormones and surgeries. It's about listening, building understanding, and creating an environment of safety. These are important aspects of caring for any marginalized population that's marginalized by medicine and marginalized by society as a whole. Recognizing patients' gender and using correct names and pronouns I'll talk about is a bare minimum. And it's really talking about building off of that. It's really important. And we affirm one's name and gender all the time on a daily basis to one another in general. It's really important before we think about how to provide, or create affirming spaces is to really look inwards and examine your own assumptions and implicit biases. You can't, correctly guess someone's gender or sexual identity based on their name or how they look or sound. It's important to avoid assuming gender with new patients instead of saying, he is here for his new patient. Use terminology like the patient's here in his waiting room. Instead of asking if they have a wife, just asking if they're in a relationship. Again, identity doesn't always equate behavior. Someone may say they're heterosexual, but that does not in any way define their behaviors or their fantasies. I've moved away from asking about sexual orientation and really just, as an HIV and STI doc or a sexual health doctor, I ask, what are their sexual behaviors? Tell me what kind of sex that you're having. And again, the meaning of sex differs between who you ask. Sex may or may not mean intercourse for certain groups, may or may not mean oral sex for certain groups. Oftentimes defining these activities as sex is important as you're sort of asking or trying to figure out, your patient's history. Again, all people should be identified by their lived names and pronouns, and even when a patient is not present, to always use their lived names and pronouns, even in their absence. Again, if you're unsure about a patient's name or pronoun, just asking. I like to be respectful. What's the name or pronoun you'd like me to use? Oftentimes, I introduce myself with my name and pronoun and ask them about theirs. Understand that dead naming in medicine or using someone's past name is sometimes unavoidable, and it's important to be cognizant of if and when this happens. And if a patient's name doesn't match their insurance status or medical records, asking sort of open-ended questions like, could your chart or insurance be under a different name, or what is the name on your insurance? A curious stance with open-ended questions always allows the patient to respond honestly without making them feel pressured. Since I have a captive audience, I'm going to give my sort of 2 cents on taking a sexual history in general. And, I think all of us can learn from a refresher of taking a sexual history, and not just of, our LGBTQ populations, but of, all of the patients in general. I always give a preamble that emphasizes sexual health, like saying, hey, I'd like to talk to you about a few minutes about sexual health and sexuality. Or, I talk to all my patients about sexual health because it's such an important part of their overall health. I offer opt-out HIV and STI screening to all of my patients. I think that's also a really important process to take or to implement in your own practices in general. Ask, framing it in a way like, first, I like to test all my patients for HIV and STIs. Do you have any concerns about that? Really offering it first and allowing someone to opt out if they don't feel comfortable, versus asking someone if, they would like that testing to be done, which can, again, oftentimes paint people into a corner and may not make them feel comfortable to say yes in certain issues or feel empowered to say yes. Asking open-ended questions. So really moving away from the dogma of, saying, do you have sex with men, women, or both? Asking an open-ended question like, just tell me about your sex life. What are your biggest sexual health questions or concerns? Or how is your current sex life similar or different from what you think your ideal sex life is? These questions may feel silly or may feel maybe really intrusive to you right now, but I will say these open-ended questions help me identify things like intrapartner violence, human trafficking directly in my clinic by allowing patients to have free reign of talking about their sexuality. And oftentimes it's the first time they've been able to openly discuss this in an exam room. And then probing further based on the information you've gathered, and then putting it all together, saying, as I've said before, I'd like to test you for XYZ based on, our conversation here. The CDC has these 5 Ps of sexual history taking. So if you're a big, fan of acronyms, you can think of these 5 Ps as partners, practices, protection from STIs, past history of STIs, and planning or prevention of pregnancy. I think these are all encompassing and really, help you think about, what are the most important aspects of a sexual history you should be thinking about. I've been encouraging and the CDC to think about a 6th P, and that's pleasure. I think so much of our work work around sexual health and sexuality has been a disease-based focus, without understanding that sexuality and sexual health go so much further than whether or not someone has an STI. And so really thinking of work through a pleasure lens is also, I think, equally important. When we think about sort of approach to healthcare specifically for transgender populations, again, a person's name and pronouns may not always match what's in the chart, and to always ask them what that name or pronoun is that they would like, and advocate for a gender-affirming EMR, which I'll talk about towards the end of my talk. Many transgender folks have had prior negative experiences with the medical system, and so don't take their mistrust personally. Allow the patient to feel in control of their decisions, and don't ask sort of unnecessarily or curiosity-driven questions. Apologize if you make a mistake. Many transgender folks have experienced prior violence, including sexual violence. And so oftentimes we want to minimize, and this goes across the board to anyone who's experienced sort of sexual violence, to minimize the amount of time someone may have to be undressed, only performing a genital exam when needed, and explaining why the exam is needed, to describe it first and allow the patient to decline it at any time. And knowing that gender-affirming therapy differs over time and between individuals, and healthcare, including physical exams and cancer screening, should be tailored to the patient's current anatomy. Part of creating a sort of a safer space or affirming space in medicine is really creating an environment of accountability, to respect sort of everyone, to work together, to not be afraid to correct your colleagues if they use a wrong name or pronouns, or if they make insensitive comments. And, you know, when I talk to medical students or trainees about this can often be very difficult to have the agency to advocate, but that advocacy is really critical. And again, creating that environment of accountability, again, is really important to maintain or sustain an affirming space like this. And as a healthcare provider and a clinician, it's really important to manage your expectations. You are not the first healthcare staff person, you know, a queer person has ever met. And if a patient has experienced insensitivity, lack of awareness, or discrimination, they may be on guard and may be ready for more of the same from you. Don't be surprised if a mistake, even an honest one, and even one that maybe feels small to your mind, results in a large emotional reaction. Don't personalize that reaction, apologize for it, and move on. Again, just the apology itself, just saying I'm sorry, can often be enough to diffuse a difficult situation and try to reestablish constructive dialogue about the need for care. It's also important, you know, we started talking about sort of individual, sort of implicit biases and where your own blind spots are, and then moving on to sort of systems, and recognize and understanding systems of oppression. It's important to seek knowledge about the political, societal, and economic realities of LGBTQI people, avoiding depending on a sole or merely a few sources of knowledge, developing critical thinking skills for yourself, that you're able to differentiate studies, articles, blog posts, social media, that you're reading on a regular basis, to be able to use your own critical thinking skills of what's the agenda here and what's actually going on. And recognizing that the lived and personal experiences of LGBTQI people constitute a valid source of knowledge for their own healthcare. And really, I think moving towards a focus on self-humility, then trying to achieve the state of all-encompassing knowledge or awareness. Understanding that terminology around sex and gender will constantly change. Understanding that, you know, newer generations will have different ways that they construct or think about framework around sex and gender, and that's okay. That's how society progresses. And really coming from a place of self-humility, that you're always learning, that you're never an expert in this, is really important. What are tangible ways that you can create sort of a supportive space in healthcare? Things like, you know, pronoun badges on name tags, working towards becoming a healthcare equity index from the Human Rights Campaign, pins, buttons, other flair that you can have on in your clinic or wear on you, to allow folks to recognize that you are potentially a safe space to discuss issues or concerns that someone may have. Working with your EMR to incorporate sexual identity and sexual orientation and gender identity collection regularly or routinely in your EMR. Going back to, we can't really find inequities or disparities in health outcomes if we're not actually counting individuals. And, you know, the majority of EMRs have the capability to do this, and having a team to work with folks and rolling it out, not just among, you know, clinicians and physicians, among other frontline staff, is humongously important. I invariably always get the question or comments that, you know, this feels just performative. You know, wearing a name badge just feels performative. Wearing a rainbow pin feels performative. And I understand that cynicism. So this is, I don't know if you guys followed the Met Gala back in 2021 when AOC wore a dress that said "Eat the Rich," and everyone was saying, "Oh, AOC is just being performative. That AOC's dress is performative. Criticizing the dress is also performative. Everything is performative. We're all performing. Welcome to clown school." I think when you attract that cynicism and are sort of hell bent on remaining in that cynicism, that continues to just snowball into more and more cynicism, where you can really make a comment about anything we do in medicine is maybe performative. Just being nice to someone is maybe performative then in that regard. Know that these actions that we take, whether they be passive actions or active actions, do have clear impacts on our marginalized populations. Wearing a pin or identifying as a safe space in your office or your clinic or whatnot will attract folks to come to you and talk to you about concerns that they may have not felt comfortable talking to any other healthcare professional. And so while wearing name tags on your name badge may feel performative, and you may have other patients make fun of you, or and say like, why do you need to wear that? It's because it matters for the folks that it truly matters for, and it doesn't harm the people that it doesn't benefit in general. We can't talk about LGBTQI health without talking about the landscape of where we are in this country today. The ACLU is tracking over 500 anti-LGBTQIA bills in the United States as of May of this year. And what we're seeing is a concerted, organized attack on the livelihood of LGBTQI people from the cradle to the grave. This is, these laws, these bans, these bills impact the entire lifespan of individuals who identify as LGBTQIA, from childhood to reproductive age, to adolescence, to adulthood, to older adulthood, and end of life itself. Studies have shown that cities are reporting more anti-LGBTQI incidents over the past 12 months in the setting of these rising bills, and things will only get worse. I think it's important to sort of brace for that as well. And we in medicine have already been pulled into the fray when it comes to affirming care for youth, gender-affirming care for youth, which has been the majority of these bills that have been working to block. But then also these bills, building off those bills, blocking the access to affirming hormone therapy for adults as well. And that understanding that, there is a concerted effort of erasing this population entirely from the US, which is not going to be possible, but clearly going to continue to cause harm for the years to come. And again, becoming or all the more reason why identifying as an affirming space for individuals to come to seek refuge, to be able to just get basic healthcare, is so important. Again, I think it's important. I just want to take a moment to recognize the Pulse massacre that occurred 8 years ago to this date, and remembering the 49 individuals that lost their lives due to the senseless tragedy and gun violence. I said there'll be plenty of time to take questions. I'm happy to take any questions folks have about this or sort of any other topics related to sort of, again, creating sort of LGBTQIA affirming spaces in healthcare settings.
Any questions from the audience?
Yes, I have a question. Oh, I'm sorry, I didn't mean to cut off. But in preparing residents to work with patients, what, for states that have been considered these almost like haven-like states where people go to seek care, New Mexico being one of them, what are we seeing integrated in the medical curriculum that is really advocating for this inclusion within the medical system?
Yeah, so I have some slides on sort of medical education and LGBT health education and medical education that I didn't include or didn't present. We are seeing, fortunately, much more time in medical curriculum talking about all marginalized populations, talking about social determinants of health, giving medical students and medical trainees some context of thinking about health outcomes. That you can have the best blood pressure medication in the world, if it's not going to get to the patients who need it the most, it is completely useless. And having an understanding of framework of how social determinants work in this world is so important. So there has been more and more time devoted to looking at how marginalized populations navigate the health system, and part of that is looking specifically at LGBTQI people. The caveat there is there's no structure to it. There's no unified structure or unified way that that medical students medical schools are going about doing this, and that goes to also saying about nursing schools, about PA or MP schools as well. And so while we are seeing increased amounts of curricular changes and education, there's no organized or comprehensive effort of standardizing that kind of education across the US. And I think that is a major area that is needed for improvement.
And just a short follow-up to that. Is that because individual medical professionals are including this in the medical curriculum, or is it the medical curriculum itself doing this?
Yeah,
I can see a change there. Yeah.
Yeah, it's both. It's both. So I can tell you that we've been seeing, the medical curriculum has been changing dramatically, in specifically in med schools in the past several years, as we think about more e-learning, more self-directed learning, et cetera. At the same time, a lot of folks have utilized this time of change to be able to integrate more sort of patient-facing and patient-centered sort of curricula in there. And again, this is not specific to just LGBTQIA populations, but really think about any marginalized population in there. Thinking about and that's both curricular changes, but the reason there might not be a clear, I think, unified approach is because every med school has been approaching this in their own sort of unique way. And also recognizing that some of these legislative changes are also impacting the way medical students can and cannot talk about marginalized populations. And also understanding that, these don't say gay bills are also moving towards, we can't say racism bills, or we can't say that there is racism in healthcare. And so this is not just these bills are not just impacting LGBTQI Americans, but really impacting all marginalized Americans.
Thank you so much.
I see we have a question from Gage Burnett.
Hey, yeah, thank you. So you talked a little bit about, the different language that people use, especially, trans people using different terms to describe their anatomy that may be different from what the actual medical terminology is. How do we make sure that providers are educated on what some of these different terms might be without running into the problem of like trans people having to educate their provider about their bodies?
Yeah. So what I always, I think it's important to leverage what we have to our benefit. So, having the ability to utilize our EMR to be for individuals to actually self-identify and then also put into their own sort of EMR what types of surgeries they've had, and which can indicate what types of cancer screenings they would be recommended for, or whatnot. I think it is paramount, and allows health providers that access to information really early based on terminology that patients are more comfortable with it in general. I think any person that or healthcare provider that wishes to expand their work within trans and gender diverse communities owes it to themselves to actually take coursework, and there's plenty of it out there that is trans-led and trans-focused on the care of transgender individuals. By no means is anyone an expert, by no means am I an expert, but the National LGBT Health Curriculum is a great place that I often refer folks to, as well as the Fenway Institute, that is constantly updated, again, led by trans individuals and content created by trans individuals for healthcare providers who want to learn more or have that who are looking to expand their patient base in general. I hope that answered at least somewhat of your question, Gage, but yeah.
It does, yeah. Thank you so much.
Any other questions from the audience?
I do have another question. based on these inclusive practices that you yourself have used, and I'm assuming the place that you work at is also using, have you seen an increase of LGBTQIA plus individuals seeking healthcare and staying as a patient and not necessarily dropping off? Or has that really not been seen as much?
Yeah, I mean, it's hard to know what before was because we weren't even collecting data. So we don't even have like how many LGBT patients were we even seeing before we were able to collect this data itself. What I will say is, we are the largest academic center in the south side of Chicago, the only academic center in the south side of Chicago. So when people want, a cancer referral or a surgical referral, or if we're not, trans people break their arms, trans people need need heart surgery. Trans people need the same types of care anyone else does. And so being able to be, a coronary care center that is trans affirming, I think has allowed folks to be able to not have to commute across town to another institution or whatnot, be able to stay within the South Side, within their communities, within their providers in a way that they weren't able to before. And so I think that difference we definitely have seen, and we've tried to make much more visible, online or in our digital footprint, to know that folks who live on the South Side who are looking for trans affirming care, and not just hormones and surgeries, but like everything else that trans people need in order to live happy and healthy lives, they can access within our institution.
And with that, I know you mentioned like the digital footprint. What other efforts have you all engaged in to get the word out? So that, because I know that sometimes one of the biggest issues is the information doesn't get to the population that it really needs it. Yeah. So one of the things that I often like to look into and also involve students in is, how do we effectively communicate all the efforts that you all are putting into this community and get it out there so that the community actually knows what you all are doing and feel confident enough to go to you and know that they're not going to experience discrimination, anything like that?
I mean, building those community relationships takes time. The trust is earned, it's not given. And that stems from, I think, a wealth and an abundance of negative experiences that trans and other sexual minority folks have had in health systems. And so that wariness, that reticence is completely appropriate. And so for us, it was really time. So, we have been building strong collaborations within CBOs and NGOs here on the South Side of Chicago around my work around HIV and sexual health and STI for over a decade now. And so leveraging those partnerships, going to their town halls, their meetings, talking about, hey, we're creating a transgender program here. Hey, like, this is what we're looking at. Like, what do you think of this? Even when we were thinking about hiring a transgender surgeon to do for our gender affirming surgical center, they were interviewed by our CBO, by our community advisory board as well, because we wanted to be vetted by the community and also feel like they have a say and are empowered by the healthcare that they receive. And so there's no easy way, Gabriella, to make it happen. But it really takes time. And again, I think words are really easy, but it's really about actions, right? It's like, are you really bringing them to the table? Are you really, holding yourself accountable to the needs of this population?
Thank you.
Dr. Hazra, I have a question. New Mexico is kind of seen as this island for gender affirming care, sandwiched between Texas and Arizona. So in terms of that, we do have people that come here to New Mexico to seek gender affirming care treatment. But one of the things to also take into consideration is that New Mexico is generally viewed as a state that is not financially well off. So a lot of the population here lives below essentially the poverty line. So what suggestion would you have to patients that come here seeking treatment, but can't necessarily afford that treatment?
Yeah. So, I mean, I think for patients who are uninsured or underinsured, I think there are several sort of what we call like pink pages. So there are like directories through the Gay Lesbian Association, Medical Association, that you're able to sort of reference that, docs who are affirming or providers who are affirming that work in area that, or that you'll be able to be seen for care, regardless of ability to pay. For example, some of the work I do here is at Howard Brown Health, which is a large FQHC here that does a lot of affirming care. And so I think there are already directors and providers across the country that, self-identify as, a place that you can receive affirming care. And if there are someone who is under status, sort of have that access available.
Thank you. All right, do we have any other questions from the audience?
Mario, I see that Gage still has their hand up. I just wanted to make sure that
it didn't auto lower.
question.
Sorry.
Okay.
Just
My
checking.
bad.
All right, so no other questions from the audience. Dr. Hazra, do you have any final thoughts that you want to share with the group?
No. I mean, thank you for having me. I think, again, oftentimes, like I always say, this talk is really just the beginning. It's like a primer to think about how to really engage more of this community in your practice. But thank you for having me. I really appreciate the opportunity.
Dr. Hazra, thank you very much for joining us again today. Everyone else, thank you for joining us and have a great rest of your day.